Thanks everyone for joining us for this CME here this afternoon on clinical clues and diagnostic pearls in treating ATTR CM. I just want to thank Alnylam Pharmaceuticals for providing the educational grant, and I also wanted to thank Vox Media for sponsoring the symposium. Please, if you could, complete the pre-symposium questionnaire right now. And personnel are collecting the questionnaire right at this time. To receive credit, CME credit, please complete the evaluation form on your seats and return it to the staff at the end of the meeting. You can see the faculty disclosures that are inside the handout. Representative slides are included as well in your handout, and I thank my colleagues for preparing them. Presentations can be viewed, if you want to look at them later, on the cmepplanet.com. Question cards, we'll have people around to be distributed, and they'll collect them, and you can certainly stand up at the mic at the end. And to be made aware of the full programming, you can check at CME Planet at Twitter and other social media. And for those of you who just came back, if your cell phones are on, just flip them to off. I'm thrilled to chair this session with my esteemed colleagues, Sarah Cuddy, who runs the cardiac amyloid program at Harvard University in the Brigham, an assistant professor, and Melissa Lyle, who's local, I guess, from the Mayo here, an associate professor and an expert in amyloidosis. So without further ado, I'd like to introduce Sarah Cuddy. She's going to talk to us about clinical clues and diagnostic pearls in ATTR CM and heart failure. Take it away, Sarah.
Yeah, thank you, Matt. And hopefully most of the audience were here for your excellent talk this morning, so I've been very well set up. And I'm going to go really obviously focusing on TTR cardiomyopathy because we heard a lot about AL cardiomyopathy this morning. Here are my disclosures. This will be the overview. So cardiac amyloidosis, this is a typical echo, and we heard this morning there's mainly two types we need to think about as cardiologists: transthyretin, precursor protein is the TTR protein, or light chain, where the precursor protein are the light chains. I mention the other types because as I'll go through the diagnostic algorithm later, sometimes you might just hit a point in the diagnostic algorithm where you're like, right, it's not TTR or it's not AL. There can be other types that affect the heart. Now, I only see one of these maybe a year or less, but it's just important to know if you kind of hit the end point of a diagnostic algorithm, there are other forms of amyloid that affect the heart. Then transthyretin wild type is by far the commonest form we see of this, associated with aging, as we heard earlier, mainly in men. But the variant type is also important to consider. So as we talked about, it's a single point mutation in the TTR gene that makes it more prone to instability and misfolding and forming the transthyretin amyloidosis. It's inherited an autosomal dominant pattern, but there's incomplete penetrance, which is quite important because the penetrance actually varies from mutation to mutation. And often I find the genetic counselors in our center will often send the TTR genetic variants to me to kind of burrow down into exactly which variant a patient has and what's their likelihood of penetrance. And we see here V122I, as it was called, but then it got updated by 20 amino acids, and V142I, which is the commonest variant we see in North America, mainly in patients who have Afro-Caribbean ancestry. So that's both Black and Hispanic patients, and we do see it in Caucasian patients too. The prevalence in Black Americans of this genetic mutation is about 3.4% on multiple different population studies. But we know those at 65 might only have a penetrance on echo, like typical echo features of about 10%. Now, updated data from Matt has shown that that increases with age as well, as this is kind of a disease of aging, and we see as patients with this mutation go into their 70s, the prevalence penetrance seems to be a lot higher. The commonest mutation worldwide is V30M or V50M now, and this, depending on age of onset, can either be predominantly neurologic features, either peripheral or autonomic or a mix, or if it's kind of late onset, mainly even Swedish, Japanese, it'll be predominant cardiomyopathy. And then what we also see in North America is what I call the Irish mutation. ALA60 is what we'd refer to it, or T80A. And this actually at one point was called Appalachian amyloid. And obviously with my patients, I know exactly where they're from in Ireland. So when I dig down into their ancestry, I'm like, what county are your parents from? So you kind of know when you know that, and they tell me Cork, and I'm like, not Donegal, then we're good to go. But I would not expect most physicians to get that deep into the ancestry. And it just so happened that Donegal, a lot of people from that part of Ireland ended up in Appalachia and throughout the UK. So it's important to know the variants and kind of what patients will have what, and what's the general kind of phenotype that we see in this. And definitely actually with the T88, that Irish Appalachian mutation, it often on these scales get puts into predominant cardiac features. But this is like a lot of variants, even like with people with mutations. Some families can be predominantly cardiomyopathy. Some patients can present with a profound autonomic neuropathy. So it's quite interesting. So why are we talking about cardiac amyloidosis so much over this presentation? Well, we just are really discovering the high prevalence of TTR cardiomyopathy, and really this is thanks in part to imaging advances that we've seen over the last probably 20 years at this stage. So this seminal paper in 2016 showed that a biopsy was no longer required to diagnose transthyretin cardiac amyloidosis. So in that setting, it was mentioned earlier, where you'd normal serum and protein immune fixation and normal free light chains, if you have a positive PYP or DPD or HMDP, that's grade 2 or 3 uptake, you can make the diagnosis of transthyretin cardiac amyloidosis. So this allowed us to screen those at-risk populations. So that's those patients with heart failure over the age of 65 with increased wall thickness. So in studies looking at admitted patients, this was up to 13% of those type of patients who were screened. In the community, the prevalence was around 6.5 in a study from the Mayo Clinic. And then also, if we think of our TAVR population, again, an older population with increased wall thickness. And the studies have shown a variance between a prevalence between 8 to 16% in the TAVR population. So this graphic is a bit old at this stage, but I think it's one of the nicest for kind of showing that massive growth in what we've seen in wild-type ATTR in particular. And you can see it ends at 2016, just when that seminal paper was published. And this is from the National Amyloidosis Centre in the UK. And I think all our referrals have continued on this kind of trajectory over the last 10 years. And really why we're talking about this. And also because we have therapies, which has driven so much of this, which Matt will go into later. So what's the clinical presentation? Well, as we learned, this is an infiltrative cardiomyopathy. So it can infiltrate anywhere in the heart. So not only do we get that restrictive cardiomyopathy and heart failure, but we also get atrial fibrillation, thromboembolic events. So the CHADS-VAS score doesn't really count here. Once we have a diagnosis of cardiac amyloidosis, we often know these patients are at increased risk of thromboembolic events. Unfortunately, also in sinus rhythm, not just in atrial fibrillation. Conduction system disease is a major issue, and hence issues with beta blockers, and in particular the calcium channel blockers, as was mentioned earlier. Chronotropic incompetence is something so common, and often you'll see an amyloid patient kind of saying after the diagnosis we made, they're euvolemic, BNP is stable, but they're telling you, I just can't do as much as I used to. And often if you exercise them, you just see this really flat heart rate response. And again, why they probably poorly tolerate beta blockers. They need that kind of heart rate to augment this fixed stroke volume to get a better cardiac output. So syncope, sudden cardiac death, and angina are definitely less common presenting features and would more go towards AL patients. Often if someone presents with syncope or angina, I am actually thinking more along the lines of AL amyloidosis than TTR, but kind of cardiac amyloidosis can really present with any of these. So as I mentioned, often heart failure, you'll get your echo or MRI and it'll raise the suspicion. AFib, when you think of amyloid, is if it precipitates heart failure, and then you want to get your echo, which will raise the suspicion. A lot of the time, our EP service will say this was a really tough ablation. The maps showed really low voltage. Do you think it could be amyloid? And we get a lot of referrals that way from EP. And then, as I mentioned, heart block, conduction system disease. And really, if you see a kind of rapidly progressive conduction system disease in an older person. More and more we're finding incidental pickups, myectomy at the time of surgery and obviously valve or atrial appendage pathology, but more often it's the non-cardiac pathology, such as carpal tunnel. So we know that there's a clear association where we see involvement of the tendons and ligaments often 10, definitely 5, 10, even 15 years before we see cardiac symptoms manifest. So we talk about bilateral carpal tunnel syndrome, we talk about spinal stenosis, both lumbar and cervical spinal stenosis, and also this finding of a biceps tendon rupture. Now, I don't think many cardiologists get their patients to flex their muscles in clinic, but my mentor, Dr. Falk, definitely did. He would be a strong kind of component in doing a full clinical exam on the first meeting a patient. And we found that in our clinic, 33% of the patients with ATTR cardiac amyloidosis had a biceps tendon rupture. Often, some of them don't even know it happened. A lot of them will say, I was playing tennis and I felt a ping, didn't think more about it. Oh, that happened years ago, whatever, didn't think it was related. And then in a general heart failure clinic, we found the prevalence was in less than, I think, 3%. So it can be a real key sign if they've got like multiple orthopedic issues. And that was one patient referred to me. It said, LVH on his echo, multiple orthopedic issues, difficult to control AFib. And I was like, what took you so long? That is every red flag dinging in my head. Some of the things, the other red flags we mentioned earlier are this intolerance of antihypertensives. So I know there was an excellent question, like, I see a lot of patients with hypertension and LVH on their echo. You want to have good going hypertension to have LVH on your echo. So, and definitely we'll see these patients, maybe they were on an ACE or an ARB, a beta blocker, and you're finding you're having to down titrate their antihypertensive meds. That's definitely something to think about. Persistent low level serum troponin for sure. A discordance between the QRS voltage and the wall thickness on echo, and we'll go into that further. Then family history, and obviously this relates to the mutations, as I mentioned earlier, this orthopedic black race, which is especially for those patients with the V122I mutation. Okay, so as I mentioned, carpal tunnel, in approximately 15% of patients who, in various studies where their carpal tunnel pathology was sent for histopathology, we found amyloid. Now, varying on the study, they restricted the population somewhat. We just did one at our centre, and we really didn't restrict the population that much at all. Like, we just kind of said, blanket 320 patients, we'll send PATH, and we got around 15%. At the time of initial screening, I only found one patient with cardiac involvement. So we still have a lot more to learn. I'm following 50 patients in clinic with amyloid in their carpal tunnel. Some of them come into me and they're like, yeah, I've had biceps tendon rupture. Yeah, I've lumbar spine stenosis. My other carpal tunnel's gone. And I'm like, okay, you're someone I'm going to see actually every year. And I'm probably going to put you into our REVEAL study of a novel radio tracer because I think you're high risk. Or if someone else who the pathologist said scan to mount, they're a woman in their 50s, and I'm like, I don't even think we have to worry about this too much for you. So we've a lot to learn about kind of this early detection in musculoskeletal. But as I mentioned, aortic stenosis, multiple studies. One of the first was from Matt and Adam Castano, finding that prevalence is 16% in the Columbia referral group. Since then, it seems to be a little bit closer to 8% in those with aortic stenosis who are screened. People like scores. You can see they created a score here for detecting ATTR amyloidosis and aortic stenosis. A lot of it goes on that carpal tunnel, right bundle branch block on ECG, and age over 85. That elevated troponin and really increased wall thickness. So I think, just in your older patients, it definitely, but they're all older, but definitely at the extremes of age, we see it more in the TAVR population. But it's still worth thinking about. If you think 1 in 10 patients who get referred for TAVR might have amyloidosis, and this is pretty hot off the press, showing that treating these patients is advantageous. It's not just something to say, yeah, we found amyloid, but they've also got the aortic stenosis. There is an overall benefit to getting these patients on TTR-directed therapy. So it is really important to think of those populations and screen them. So as I mentioned, the ECG can give us hints, and this is from the Mayo Clinic led by Martha Grogan. where I think they've now, Melissa might talk to us about it further later, integrating ECG and AI and helping detect amyloidosis and other pathologies. And I think Matt also published something on this just the other day. But really, the kind of often the first thing is the echo, as they say, hashtag echo first. Because usually that's what, as I mentioned, you've got your heart failure, your difficult to control AFib, let's get them an echo. And it's often at the level of the echo that we say, have we thought about cardiac amyloid? The walls are thick, atrial dilation, valve thickening, there can be effusions. A lot of people like to talk about the increased echogenicity or echo bright appearance. Definitely when you see it, it's worth mentioning in an echo report. We tried to study it. Me and another expert echo reader couldn't even agree with each other on what we'd call echo bright, let alone see how to kind of see how well it compared to us using radiomics, a kind of novel way of looking at images. The radiomics was a lot better than me and Jared. So typically we think of like restrictive cardiomyopathy, really diastolic, kind of grade 3 diastolic, restrictive filling patterns. These really small mitral tissue Doppler indices where the E prime, S prime, A prime are all less than 5 centimeters per second. And as I mentioned, aortic stenosis, particularly low flow, low gradient. But these are often signs of quite advanced disease. And this is pretty old data at this stage, 11 years ago from Christina Corda when she was working with Rodney at the Brigham. Longitudinal strain or strain of any form, really good at being abnormal in amyloid. If your strain is abnormal, that's kind of going to be pretty sensitive. But then when we looked at a restrictive filling pattern, only 35% of the patients, and if we think of 2014, this was a lot more kind of textbook cases. We weren't probably picking up the disease as early. But still, if you wait till the restrictive cardiomyopathy, you're waiting too late. At that point, we only had 35% of patients who had a low QRS voltage. So again, you don't kind of say, oh, the ECG look normal. I see plenty of LVH criteria and ECGs in my clinic. And again, we talk over and over that this is HFpEF. At that point, we saw 34% of the population we were studying had an EF less than 50%. Contemporary trial data, it's around 50% have a EF or less than 50%, often in that kind of mid-range, 40, 45. Okay, so I mentioned strain. Particularly, we talk about this apical sparing pattern. People have tried to kind of make ratios of it, and in the original studies of these ratios, they looked like they had really good areas under the curve, like 0.9, but these were in hyper, selected populations, small studies. So really not as applicable. Then there have been scores developed, as was mentioned earlier. There was one score, increased wall thickness score, developed by the group at the National Amyloidosis Clinic. I don't love it, because you have to calculate relative wall thickness, E over E prime, TAPSE, longitudinal strain, and this is the septal apical to basal ratio. By the time you've calculated all those things, you've thought about amyloid, so just do the next test. Yeah, if you're thinking about amyloid enough to calculate that, yeah, just say, I'm thinking about amyloid, maybe I should get the PYP and the light chain assessment. You could talk about integrating it into an EHR and it generating it for you. The Mayo score, as was mentioned earlier by Matt, is quite a nice way of potentially ruling out disease. And maybe if it's good enough to have a positive predictive value of 25%, if you 1 in 4, that's pretty high yield for testing, I think, for diagnostic testing. So again, reflecting that it's often older patients, men, ejection fraction less than 60, and posterior wall thickness. This is what I really like about this score. In general, we see a lot of dust in our older patients. So, if you sent everyone with a septum of 12 millimeters, you'd be screening a lot of patients. So I think it's really good to pay attention to the posterior wall, because you've got an increased posterior wall. There's something pathological happening there. And this is what we looked at in a study where Matt contributed data, and that we were made for the reviewers, not allowed to call it the posterior wall, I had to call it the inferior lateral wall thickness. So IL wall thickness in the red line nearly performed just as well as that Mayo score, which is the TCAS score. So there wasn't that much difference, and definitely performed just as well as all those different strain ratios. So if you're going to look at one thing on the echo, look at the posterior wall thickness. But maybe we don't even have to look at the echo. AI will do that for us. This is just one of the early papers in 2021. Rahul Deo, who was at the Brigham at the time, kind of used images to generate an AI tool to detect amyloidosis. There has been a huge amount on this, and recently just published was from a company, Ultramics, who worked with the Mayo Clinic, and we validated their data. So now there's actually commercially available tools that can be integrated into echo labs to help detect. So I think really it's not does AI work, it's how do we implement the AI into our work, into our workflow. So I hope I'm keeping on time. I haven't paid attention. But the diagnostic algorithm. So we've got symptoms, signs. We've done our ECG or echo. We can do our cardiac MRI. I would say never wait for a cardiac MRI to make the diagnosis. I've seen too many people say, oh, I waited 3 months to get a cardiac MRI and then I did the light chains. I was like, oh man. And we saw from the curves earlier, like that first 6 months is really key, where there's a lot of morbidity and mortality, more important. So you want to, once you've kind of thought about it, just do the hematological tests, and you can kind of order your PYP MRI in tandem if you want. I often find the MRI more helpful as I go down the algorithm. So often I think we order these in tandem, ideally maybe the hematological testing first. So if your hematological testing reassures you and you don't have any uptake on the PYP or DPD, it's highly unlikely. And this is actually where I think the MRI is most kind of helpful, because if you still have a high suspicion for disease, you might want to look for another etiology, or they might say, yeah, this MRI slam dunk amyloid, and then you're definitely getting a biopsy. We know there's different variants that can give us negative PYP, and then I mentioned those other rare forms we come across. If our hematological testing is negative and we've got grade 2 or 3 uptake, then we can diagnose TTR amyloidosis. And at that point, we do the genetic testing. If we have grade 1, well, I always want to look at the images. Was it blood pool? Is it really myocardium? Should we repeat the imaging with SPECT CT so we can kind of better attenuate for tissue correction and register the myocardium? But again, you might want to consider tissue in this case. If you think it is true uptake, because you might pick up early disease or again a rare form or a variant form of amyloidosis. If our hematological testing is positive, well, yeah, the easiest thing I think is to say call your hematologist. And as Matt mentioned, hopefully a hematologist who knows something about the disease and is familiar with AL amyloidosis and isn't just kind of like a benign hematologist. No offense to anyone who knows any in the audience. And again, I find cardiac MRI can be really useful here to kind of help fully rule out if there's cardiac involvement or not. So we talked about the abnormal serum free light chains earlier, and just to touch on it again, you know, we can adjust for an elevated kappa based on renal function. If you don't feel comfortable doing this, I think it's totally fine to find someone who does and run it by them. I get texts from my colleague who's an EP in Dublin, Ireland, saying their kappa is 40, but their EGFR is 35. This is good, isn't it? And I'm like, yeah, the ratio's normal, no monoclonal gammopathy. I'm like, yeah, you're good, don't worry about it. So this was also spoken about by Matt. So I think, like I mentioned, some of my take-home points are always look for an etiology of increased posterior wall thickness. MRI is not key to the diagnosis. It can be super helpful. I'm an MRI reader, so I don't in any means like to say it's not useful, but I never like to see it delay workup. It's actually easier in my centre to get an MRI than an echo, so we just go for it. Try not to be intimidated by the hematological workup. Just order it and call someone. And then the earlier therapy is started, the better these patients do, as we'll learn later. Okay, thank you.
Super, thank you so very much. And I don't know if I just click to get my slides or, oh, there they are, great. So these are my disclosures. I usually say I think the drugs cost too much, which we won't solve today. So this is the typical echo that you might see in an advanced patient with amyloid. The ventricular chamber is very, very small. The atrium are bigger. And physiologically what happens to a patient, so you understand, is the end diastolic pressure-volume relationship shifts upward and to the left. And so the ventricle can't fill to the same normal volume, and you can see the stroke volume has declined precipitously. Body activates neurohormones to kind of modulate that, shifts more blood back to the central circulation. So the filling pressures are high, the volume in the ventricle is less than normal, but you haven't normalized the stroke volume, so the cardiac output is still low. And if you think about this progressive upward shift in the end diastolic pressure-volume relationship, what it does is it basically, as I said, declines one's stroke volume, therefore cardiac output declines and blood pressure falls. And as Sarah was saying, these patients often present with a low blood pressure, and so you've got to put on your geriatrician hat and think about deprescribing. Do they really need this beta blocker all the time when they're trying to maintain an output and they need a faster heart rate? Do they need ACE inhibitors, ARBs, and ARNI? So we'll talk a little bit about medical therapy before we get to targeted therapy. This is a population that is with amyloid that we're increasingly seeing. There's a wide spectrum of disease, so I don't think we can take away that one size of goal-directed or guideline-directed medical therapy works. It may be different for earlier or advanced patients. And the problem we have is that none of these patients were included in any of the clinical trials that we conducted that led to the regulatory approval for HFrEF or HFpEF. And we have complicated phenotypes, as I said. They have a fixed stroke volume. Often these patients have conduction disease. They could have autonomic dysfunction. They could be frail. They could have fragile fluid homeostasis. And as a result, what's emerging, I'll show, is that SGLT2s and MRAs have a pretty big role, and you should be careful with beta blockers and ACE inhibitors and ARNI. These are data that Richard Chang and Wayne Levy helped us analyze and then publish from a while ago. These were patients with pretty bad amyloid heart disease. They're on high doses of medications when they came to see us. And you can see the beta blocker group had no clinical benefit with regard to mortality, nor did the ACE inhibitor or ARB group. Interestingly, what we found was that when we shut off the beta blocker in the group in blue, so these are people on high-dose vasodilatory beta blockers, they live longer, which was somewhat surprising to us and made us be a little concerned about instituting beta blockers for these patients. The largest series has been published by the NAC. You can see here that ACEs or ARBs confirm what we found. I'll go into these data a little more carefully, but no clinical effect on mortality. They did find this signal that low-dose beta blockers, bisoprolol, 2.5 milligrams was what they were using in those who had an EF under 40, seemed to have a survival benefit, and MRAs were effective across the spectrum of disease, whether your EF was normal or not in patients with transthyretin amyloid. There's a role, I think, as we all know, for SGLT2 inhibitors. These patients develop a cardiorenal syndrome. We've shown in others that more diuretics they take, the worse the outcomes of the particular patient. And so could these agents be useful in this regard to prevent hospitalizations, preserve renal function, and use less diuretics? So these are data from our center, again, non-randomized. This is now looking at the TTR patients. And what you can see is that we needed to use less diuretics in those in blue who received an SGLT2 inhibitor. And despite using less diuretics, in panel B, their weight went down. So they were more often losing volume and fluid. And their GFR declined initially, but stabilized over time. And Mariana and her group in London did a propensity matched analysis that was quite impressive, I thought, in which they had 200 patients who had TTR amyloid on SGLT2 inhibitors and about 200 who they matched for disease severity. And they showed that there were impressive effects on reduction in all-cause mortality, CV mortality, needing less loop diuretics, and lower risk of heart failure hospitalizations. So potentially an effective agent. Beta blockers, as I said, are usually tolerated at low dosages. Many of us use them for rate control in, for example, atrial fibrillation. Though a warning sign that you might have amyloid is if you flip into AFib, you're 80 and you're not having a very fast heart rate because you have concomitant conduction disease. There needs to be withdrawal of beta blockers in about 30% of patients in most of the studies. And the challenges to using them, as we talked about before, were conduction disease, chronotropic incompetence that Sarah mentioned, and this concept of a fixed stroke volume and them needing to maintain their cardiac output with higher heart rates. ACE inhibitors and ARBs, I said, don't really have any benefit, nor does ARNI therapy. Withdrawal is a little bit higher, these agents, than others, and it looks like they're impacted, or their use is impacted by the patient's functional capacity, and again, this concept of autonomic dysfunction. There's some interest in maybe ARNI therapy for this abnormality in RVPA coupling, and people have hypothesized maybe in the future that such agents might be useful for decreasing fibrosis, but those are areas of future consideration. And certainly, as I mentioned, both MRAs and SGLT2s, at least in our practice, are the frontline things we're always thinking about. The MRAs are very well tolerated. Again, there's a signal that they reduce mortality across the spectrum of ejection fraction, and SGLT2 inhibitors tend to prevent the need for high-dose diuretics and help maintain euvolemia, and I think may actually clinically improve outcomes in these patients. So we've moved from a period in the past where, at least 20 years ago, where AL was the dominant type of amyloid. Now it's TTR. The phenotype has changed. We've all recognized this is bordering on not even a rare disease by FDA definition, I think, and we can make the diagnosis obviously non-invasively in 80, 85, or 90% of the subjects. But the big thing that's happened is there are tons of new treatments that are available. So just to walk you through, TTR is a small protein made by the liver, mainly. A little bit is made in the back of the eye by the retinal epithelium, and a little bit in the brain. It's made on chromosome 18. It's 127 amino acids, and it looks like a tetramer, or a four-leaf clover. And in the setting of aging and or variance, the protein breaks apart into pieces, and those pieces form fibrils that get stuck in the heart. So the treatment strategies are really threefold. We can shut off the protein production. We have drugs that do that, including now FDA-approved vutrisiran or Amvuttra for cardiomyopathy. We have patisiran, an old drug approved for neuropathy with cardiomyopathy for variant patients. Aplenitersen, also approved for variant patients with or without cardiomyopathy, but not approved for wild-type patients. We're working on gene editing. I won't mention that today. We could talk about discussions. There's a phase 3 trial where you can shut off TTR production permanently and for forever. We have stabilizers, tafamidis being the first in class, acoramidis newly approved, and obviously off-label diflunisal. And the holy grail was, could we remove amyloid? And we're doing clinical trials in that regard. But the bottom line is either as stabilizers or silencers at this point. Obviously, tafamidis was the first agent, kind of surprising to all of us how effective it was. These were the data. They were patients randomized either 20 or 80 milligrams. Those two doses were pooled for analysis. Patient population is 91% male, 75-year-olds, have very thick-walled hearts, have low global longitudinal strain, and have biomarkers that are very high. I always was perplexed why they had NYHA class 2 symptoms with this bad a circumstance, and essentially like a stroke volume index that's like 25 mLs per meter squared. And I think it's because this disease is very indolent and slow. Drug was highly effective. We used this Finkelstein-Schoenfeld win ratio, became quite popularized after this trial, basically showed the chance of a win was 70% higher with tafamidis than placebo. A problem with this is no one understood what this all meant statistically or clinically, but I just point out there was a 13% absolute risk reduction in mortality in this very sick population. So surprisingly, we even analyzed the data in the traditional way with Kaplan-Meier curves, and you can see here that it was statistically significant even on all-cause mortality in this small trial with 441 patients. Not what we anticipated at the time. Drug reduces, obviously, cardiovascular hospitalizations, we know, with a relative risk reduction of about 32%. And the most important message, I think, that we still try to communicate to everyone, and it's probably most important, is it's not that important which drug you pick. It's important to diagnose the patient early and give them a drug, right? Way more important than thinking about. So these are data from the original ATTRACT trial. There were only 37 patients out of the 441, so less than 10%, who had NYHA class 1 symptoms. The confidence intervals are wide, but if you look at the point estimates, it makes the story. 64% reduction in mortality if you find them with no heart failure symptoms, class 2, 39%, and class 3, much less. So earlier is definitely better. These are data from our center that we published. Between 2001 and 2013, I had seen only 101 patients with amyloid in their heart, and everyone got a biopsy in the first blue bar. Now we see 250 new patients every year. That was, 10 patients a year kind of thing. It's exploded. Patients have much less advanced disease. The gray bar at the top of the Columbia staging system is only less than 10%, 8%, and we're using lots of different drugs. And what that's done is it's translated into, you can see in the blue or purple, the median survival was 2.5 years. Now we haven't even achieved median survival in most of our patients. This is not all because of drugs. It's because of earlier diagnosis as well as therapies. These are data that we published recently from a Taos registry, just looking in longer term, and you can see that at 30 months, the time for the ATTR ACT trial, we now have an 84% survival, and at 42 months, 77% in people receiving the drug in the real world, so to speak. This has led to an explosion in clinical trials that my colleagues have all been working on, and I just highlight that every single study we've ever done so far in amyloid has been positive. You can argue with the clinical meaningfulness of the effect, but we haven't had yet a negative trial. So kudos to the basic scientists who figured all this out. The next drug up was approved last November. It's a stabilizer acoramidis. It capitalizes on the T119M variant. And this trial, kind of, if you will, larger than ATTRACT, but mimics the design. And they showed that there was a significant effect of this agent compared to placebo on outcomes. And the most important here were death from any cause and CVH. Stabilizers, when you take them, raise your prealbumin levels. And we can talk about that, but there's some interest in following these over time. Maybe they'll have some prognostic importance. The problem is silencers lower your prealbumin or TTR levels, so it becomes confusing. These are the data that were published. Dan Judge published this in Circulation. The trial ended, as I said, at 36 months, but there was a longer-term outcome in some regard, and the drug has been shown to, over the long term, reduce mortality and has a pretty impressive effect on cardiovascular hospitalizations with a 50% reduction because the patients are more often suffering from that complication. Thankfully, they're less often dying. The approaches to knocking down TTR are really threefold. You can use an siRNA, you can use an antisense, or maybe one day we'll just gene edit and you won't make TTR for forever. But those are the first two, siRNA and antisense, are basically available clinically. The idea here is you're making a bad protein, it's falling apart, it's getting stuck in your organ, and you're causing your phenotype, and what you're gonna do is basically stop the production of the bad protein, lower the precursor, prevent any further deposits, and maybe even to stabilize or reverse the phenotype. So the HELIOS-B study took vutrisiran, a drug approved for neuropathy, and studied it in the cardiomyopathic patients. There were 654 patients in this trial, randomized 1-to-1 to vutrisiran or placebo. Highly pretreated population, 40% were on tafamidis, lots of patients taking SGLT2 inhibitors. And this trial was wildly effective as well. You can see the primary endpoint, death from any cause and recurrent CV hospitalizations in the overall population. There was a 28% risk reduction, and that was mediated by both death and recurrent CV events. And that was true in the overall population and in those who received vutrisiran without, if you will, concomitant tafamidis, the so-called monotherapy population. These are the Kaplan-Meier curves from that particular trial that were published in the New England Journal by Mariana and colleagues, again showing impressive effects on outcomes of death and in the overall population in the monotherapy group. So clearly a very effective agent. And there have been a few sub-studies that have recently been published. This trial did not include advanced, if you will, New York Heart Class 3, NAC Stage 3 amyloid patients. They were excluded, so it was more a Class 2 population, but you can see across the spectrum of who was included, NYHA Class 1, 2, and 3, NT-proBNPs low or high, whether it was with recurrent events or all-cause mortality, there was no heterogeneity. The drug was effective across the spectrum of disease by severity of heart failure. And more in-depth analysis of the cardiovascular events was conducted by Ron Watellis and published similarly in JACC. And I'd say most impressively, a lot of these urgent heart failure visits that we talked about earlier today and several discussions about increasing oral loop diuretics or needing to go, in this case, to an emergency care setting were markedly reduced by this agent, along with all the other morbid events that we were interested in. And while these drugs don't on average make people feel better, they basically slow the decline. The data from the HELIOS-B trial also showed that there was kind of an increase, if you will, proportion of patients who maintained or even might have slightly improved their functional capacity and quality of life, although that wasn't the majority of the folks. In general, they slowed the decline, but if you find someone pretty early with very few symptoms, that's really a success. So there are lots of unresolved issues now that we have multiple different therapies, and I don't have answers to any of these questions. We just posed them in a review we wrote with Pablo Garcia-Pavia and Esther Gonzalez from Spain. We don't know which therapy we should start first. We don't know if we should ever switch them. We don't know if there's long-term safety about any of these therapies, how much do they cost, should we combine therapies? And I don't have any answers to these definitively. I'm going to give you my quick perspective. And that is shown here. So these 3 trials are probably not easy to compare. The bottom line is they were conducted, as you can see, in eras very different. One 10 years ago or more, 15 years ago, and the patients enrolled differ, right? There's a lot more variant patients in the ATTR ACT trial. We've been less successful. You can see the placebo mortality has gone from 43% to 26% to 18%. You guys are doing a great job. You're finding people earlier. They're not getting any treatment on the placebo arm. They're just improving their outcomes. And the event rates are lower because patients are diagnosed with a lower NT-proBNP and less severe heart failure. And Brett Sperry showed this really nicely. Don't look at the, just look at the placebo arms of each of the trials and you can see that they're just improving. That just means that people are diagnosed at an earlier stage. So with all the caveats that are hard to compare, when I look simplistically at the hazard ratios for mortality, CV events, 6-minute hall walk, and KCCQ, and the differences in the confidence interval, you can look across them all, but we publish this, they're all overlapping, right? Meaning they all work, and I don't think anyone can convincingly say to you at this point, we know that one agent is markedly superior to another. So I will conclude there. We'll be open for discussions. I'm sure there'll be a lot of that. And I really am grateful and welcome Melissa Lyle, who's going to run through a case with us about how we might manage heart failure and comorbidities in ATTR CM.
All right, thank you so much, Matt. And so Sarah and Matt have given great lectures, and now I just get to do a case to kind of pull it all together. So this is going to incorporate managing heart failure and comorbid ATTR cardiomyopathy in the clinical practice setting. And I have nothing to disclose. So a 68-year-old female presented with ongoing dyspnea. Her past medical history included atrial fibrillation, and she had had 3 prior ablations. So Sarah already mentioned that refractory atrial fibrillation with multiple ablations as being one of those clinical clues. On her physical exam, she actually had periorbital purpura, macroglossia with teeth indentations. She was quite volume overloaded with JVP elevated to the angle of her jaw, a 2 out of 6 systolic murmur at the left lower sternal border, and had lower extremity edema. So here's just an example of her periorbital purpura that she actually had been struggling with for about 5 years, had seen multiple different physicians, and had just been told that she was easy to bruise. So prior to seeing me, she had her ECG, which does show normal sinus rhythm at that time with some PVCs. As Sarah had alluded to earlier, we do have an artificial intelligence ECG tool that is embedded into our electronic health record. And so this is very useful as we're starting to look at a screening tool for amyloid. So if you see here, her prior ECGs from 2015 were normal, but then more recently, her ECGs were high probability of amyloid. So because of all of her symptoms and her cardiac history, she had an echocardiogram that was done, so very similar to what you've already seen today. She has very prominent increased left ventricular wall thickness. So her interventricular septum was measuring around 14 millimeters, and her posterior wall measured around 15 millimeters. You don't see her right ventricle as well, but she also had increased right ventricular wall thickness. Sarah already mentioned the apical sparing pattern, but you can see that her global average longitudinal peak systolic strain was low at -11, and much more affected at the base and mid-ventricle with relative apical preservation. So because of those clinical clues she presented with, and because of her imaging findings, we of course had a very high suspicion for amyloid. When I first met her, my suspicion was very high for AL with her periorbital purpura, which is thought to be more pathognomonic. So we got initial laboratory evaluation with hematologic screening. You can see here, so creatinine normal, 1.2. Her kappa free light chain was 3.56, lambda was 1.18, and her ratio was 3, so elevated even in the setting of a relatively normal renal function. So her serum immunofixation did demonstrate a small monoclonal IgG kappa. Her urine immunofixation also demonstrated that. And as part of her initial testing, we had cardiac biomarkers. Her high sensitivity troponin was 67, NT-proBNP was 3,499, and her prealbumin was low at 9. So you've already heard from Sarah and Matt about this kind of initial algorithm, but again, just to reiterate, so clinical clues, her atrial fibrillation that was refractory to ablations, her symptoms, especially her periorbital purpura, and then her echo findings. So when you have that clinical suspicion, moving down to the hematologic assessment for AL first, or as Sarah mentioned, getting it in conjunction with each other with a nuclear PYP and light chains. But just with this algorithm, a little more straightforward, getting the hematologic assessment first, serum-free light chains, serum and urine immunofixation, not just SPEP and UPEP alone. If there is a monoclonal protein, relying on our hematology colleagues to help us with that next evaluation, often getting a fat pad and a bone marrow biopsy. If those are negative for amyloid deposits, but there's still high clinical suspicion, moving towards biopsying that most affected organ. And in our case, endomyocardial biopsy. But again, as Sarah had demonstrated, if negative monoclonal protein, negative hematologic testing, that's when you can utilize cardiac scintigraphy. But in our patient's case, because of her monoclonal protein, she was seen by our hematologist. She had a fat pad biopsy and a bone marrow biopsy, both which were completely unremarkable. Amyloid deposits were negative and really no concern from the bone marrow biopsy. But of course, there was still concern for an infiltrative process. So she had an endomyocardial biopsy. And I love this acronym from Dr. Dan Judge, and this slide was shared with me from my mentor, Dr. Martha Grogan, that if you have an MGUS, you must go under the skin. So she was diagnosed with a monoclonal gammopathy of undetermined significance, but we did proceed with that endomyocardial biopsy for her. And surprisingly, so she had amyloid deposits detected by Congo red staining, but when we sent for amyloid typing by mass spectrometry, it was actually transthyretin amyloid, to all of our surprise. I really thought this was going to be more consistent with AL. And she had genetic testing, which was consistent with the T80 ALA, or now legacy T60 ALA mutation. Throughout this process, she was describing symptoms of neuropathy, so she was referred to our peripheral nerve team. She had electromyography as well as an autonomic reflex screen. And this was indicative of both a large and small fiber neuropathy. That autonomic reflex screen can be very helpful for picking up early small fiber neuropathies and autonomic dysfunction. So she comes into clinic to discuss initiation of disease-modifying therapies. And just as Matt really eloquently described, we have a discussion with all of our patients about which drug to choose. In her scenario, we had lots of different options, but not really having evidence to support one better than the other. We had discussions about concomitant therapy for her, stabilizer and silencer. She did experience some financial constraints with stabilizer therapy, so we proceeded with vutrisiran monotherapy. And she was doing well, but started to struggle with increasing fluid retention. She had been on furosemide. I switched her to torsemide for a diuretic with better oral bioavailability. I put her on spironolactone and then also added on an SGLT2 inhibitor because we just learned that benefit of MRAs and SGLT2 inhibitors in this patient population. But she came in 3 months later, still feeling like she was progressively declining, and she felt more symptoms with her palpitations. She was struggling with symptomatic paroxysmal atrial fibrillation, and she had actually been on a low-dose beta blocker, but not really tolerating it. We re-referred her back to electrophysiology since she felt her symptoms were only when she was in AFib. They discussed repeat ablation, that would have been her 4th ablation, or consideration of antiarrhythmics, and she really felt so symptomatic in AFib that she wanted to focus on maintenance of sinus rhythm, but wanted to avoid future procedures, so she opted for admission and difetilide loading. She did well for a time, and then 6 months later, though, again, progressive symptoms, even in sinus rhythm. Had not had any recurrence of her atrial fibrillation, but further decline, now describing NYHA class 4 symptoms. increasing diuretic requirements as well. Her dose of torsemide went from 20 milligrams BID to 60 milligrams BID, and we know from the Columbia staging that as that increasing diuretic dose, increasing symptoms with worsening functional class, all of that tells us worse prognosis. Her high sensitivity troponin was 75, NT-proBNP was greater than 4,500 with relatively similar renal function. So because of all of the progression of her symptoms, we decided to evaluate her for advanced therapies. So she had a cardiopulmonary stress test and a right heart catheterization. So on her CPET, she only exercised for about 2 minutes, but she still gave a good maximal effort. She had a respiratory exchange ratio of 1.15, but her peak VO2 was only 9. And as most of you know, when we think about those cutoffs for consideration of advanced therapies, we think of 14 and then 12 if someone's on a beta blocker. So she was definitely meeting criteria for consideration of advanced therapies. Her ventilatory efficiency was also very ineffective, and her VE-VCO2 slope was quite high at 49, with anything over 35 being considered a worse prognosis. Her right heart catheterization really further demonstrated what we already knew. Her RA pressure was elevated at 15, her wedge pressure was elevated at 28, and her cardiac index was low at 1.4. So she was referred for a heart transplant evaluation, underwent the evaluation, was approved and listed as status 4. So the OPTN, or Organ Procurement and Transplantation Network, changed the allocation policy in 2018. So all patients with restrictive cardiomyopathies, including amyloid, are now listed initially as status 4. And that helps in terms of waitlist mortality and quicker to undergo transplant. So she underwent a successful transplant, and this is her new heart, so she's doing fantastic. And she was continued on vutrisiran post-transplant in order to try to prevent the progression of those extra cardiac manifestations. So I think this case really highlights a nice multidisciplinary approach. So she first came in through cardiology due to her symptoms. She, of course, was seeing electrophysiology for the recurrent atrial fibrillation. She was seen by hematology and continues to follow with them for her MGUS. We needed an endomyocardial biopsy and our pathology colleagues to tell us that amyloid typing. She has neuropathy, following with our peripheral nerve team. She, of course, underwent a transplant evaluation and later transplanted. Palliative care always involved with those end-stage cardiomyopathy patients. And then from a genetics counseling, not only for her initial genetic testing, but also for her family members. So she's doing fantastic 1 year post-transplant, and then she had 3 siblings, all who underwent testing and tested positive actually for the mutation. And Sarah alluded to the different phenotypic presentation, and her family really highlights that because one member had NAC stage 1 NT-proBNP of 950. That brother was on acoramidis and has been enrolled in Magnitude, the CRISPR study. Another sibling had NAC stage 2, NT-proBNP was pretty high at 3,500 on vutrisiran and in the deplete TTR, one of the depleter studies. And then another sibling was a carrier, and it is now in the ACT early study. So Matt already highlighted this as well, but we still have a lot of challenges and a lot of questions we don't have the answers to. So what is the choice for initial therapy? Do we need to switch? Do we need dual versus monotherapy? The best way to manage congestion in these patients when they really start to become refractory to diuretics. The best way to monitor disease progression, we kind of briefly talked about that use of the prealbumin, and if you noted on her initial testing, her prealbumin was quite low, but now we know that it's going to be low, that she's on vutrisiran. And then when to consider advanced therapies like heart transplant. And so I would love to get Sarah and Matt's thoughts on the case and anything that you have to add.
First, I'd say thanks very much. Really fantastic. I personally think the case nicely highlights a lot of the issues and challenges. We're trying to stamp out the need for transplant, but it's certainly an effective strategy. And I would comment, I think it's, you mentioned, but maybe you can clarify further. I think it's important to not stop, disease-modifying therapy for these patients because they're still producing, a misfolded TTR in this case. And, with the process of what they call seeding, where you have amyloid in other organs, it could progress. But could you
Yes.
comment a little bit further about,
Yeah.
post-transplant care and the need for continued amyloid therapy?
Yeah, absolutely. So we've highlighted that in actually a couple of studies. When I was at Emory, we looked at a population of V122I patients that had progressive extracardiac manifestations post-transplant. This was in the era before disease-modifying therapies. So our patients did really well from survival outcomes from a heart standpoint, but struggled with neuropathy, gastroparesis. And so even though we were starting silencer therapy after transplant, it was a little delayed when they already had significant symptoms. So I think it's really key in our transplant practice, every patient is on disease-modifying therapy post-transplant. I think that especially our hereditary patients, that's what we're trying to prevent, is that progression of the extracardiac disease. And it's interesting because my colleagues in Rochester, Dr. Rosenbaum, had shown actually even with wild-type TTR, they looked at 10 patients, and we often talk about that there's not neuropathy associated with wild-type, but they found that those 10 patients with wild-type did develop neuropathy later, and so we think that we allowed them to have a longer lifespan, and then they still developed extracardiac manifestations.
Great.
So very key.
Open to questions. Dr. Allen? I hear you, but I don't know if everyone
Thanks
else
for such a nice session. So I have a couple of patients who my impression is that they have actually had response to therapy. Their decline has slowed, but as you mentioned, they still get worse. And so after some years, they're frustrated. They're older, so not transplant candidates. And so they're pushing very hard to change their therapy around. And I guess I would say, one, you said we don't have data to tell us what to do, but the question would be, do you change them around, and what do you tell them? Because even though we don't have the data, they're in your office and they're afraid of dying, and they want an answer about why you're not giving them dual therapy.
Yeah, Larry always asks really good questions, so that's a great one. I'll tell you what I don't know what I tell every, I have a discussion with each patient. I wrote this piece in the Journal of Cardiac Failure about this a little bit. My concern is that people with amyloid could progress, but it may not be because of TTR biology. We're all, compassionate, good human beings, and I think when you see someone in front of you who's not doing well, your tendency is to think, what else can I do? And I don't personally have an objection to them switching a therapy. I think combining therapies is maybe a bridge too far given the costs, but some of them want to do that. But I think the concern I personally have, and I tell them, is I'm not sure this is going to make you feel better, function better, or do anything better. I personally believe maybe if they're not optimized from a heart failure perspective, right, they're not getting the optimal or best diuretic, they're not an SGLT2 or an MRA, those are much lower hanging fruit to think about, but most of us hopefully are already. But that's my perspective. And I know it's hard to stop that train, but I think you have to have equipoise and let people know that we can throw more at you, but more may not be necessarily better. It could be, but we just don't know. You guys, thoughts?
Yeah, it's super hard. Like, I'd love to say the data says don't, like, switching, especially in NAC stage 3, where there was no NAC stage 3 patients really in the Helios-B study. And we know that they do the worst over time and probably have the least response to TTR target therapies. But just yesterday in clinic, a NAC stage patient in front of me, and I said, yeah, I'll switch to vutrisiran. Because that's kind of, I'd love to kind of say it's not going to do much, but I said, look, let's go out on a hope and a limb that it'll do something, I don't know, because it is still the patient in front of you. So I'd like to say I could be as stick to the data as I would present, but sometimes it's just so tough when that patient's in front of you.
I agree as well, but I do think to Matt's point about making sure the other heart failure meds, because so many times that I see people with that same scenario, that they feel like they're not improving, but then they're on a high-dose beta blocker and they're feeling fatigued. I wean their beta blocker and they feel a lot better. They're on Lasix. and I switch them to torsemide or Biomex, and they feel so much better. We add on an MRA and an SGLT2. So I do think it's the tough scenario when someone is completely optimized on all of those things and then still not doing well. And then I think it's reasonable to have those ongoing discussions.
Yeah, I got some good questions. I don't know if you
Yeah, sure. I was just going to say to Larry's point, we have a switch study that we're trying to conduct to collect some data to try to inform this. We'll see what happens, but switching people from one agent to another and actually trying to track their outcomes to see if we're meaningfully trying to improve what we hope patients want.
So this said fat pap biopsy role, do you consider deep fat tissue biopsy surgically rather than an aspirate is more sensitive? Great, I'll take this and then I'll ask that. There's a few questions here. So definitely aspirate is less sensitive than an actual biopsy. We actually do a skin punch biopsy at our center, not a fat pap biopsy, because our pathologist loves getting dermis and will kind of go searching through the dermis, not just the kind of fat, to look for amyloid. So definitely kind of as much tissue as you can get them. So we tend to do a skin punch biopsy. I don't know if you guys do fat pad or fat aspirate.
Yeah, we do fat aspirate, but I would say, and we do skin punch in certain scenarios. But I think that if I come back and it's negative, there's still high suspicion. We are fairly quick to then jump to an endomyocardial biopsy if we think that it's needed. We actually do echo-guided endomyocardial biopsies in our own procedure room, so it's easy to schedule. I can even do it same day if I see someone, and we typically have availability. So that can be our backup if we are having trouble with the fat aspirates. And
I would just comment and say that a fat aspirate has a sensitivity of about 30% for wild-type TTR amyloid, so you can't stop your workup after a negative fat pad biopsy and say, oh, you could have a life-threatening disease. I'm just gonna not work you up any further. So it's fine if you want to do it. We don't do them, and the cardiology group, our hematologists do them, but I personally don't find them that helpful.
Yeah, not for ruling out TTR for sure, either fat pad biopsy or aspirate. So I'll direct this question to Matt. How frequently do you repeat cardiac biomarkers while on treatment?
We generally repeat them at most visits, though if someone's being seen like every week because they're decompensated, we don't. In general, we have a program in which we measure NT-proBNP, high-sensitive troponin, prealbumin, EGFR every 6 months in our patients. We also try to do performance testing, 6-minute hall walk, short physical performance battery, because that really reflects a lot more of what they want. And then we, I think we're torturing them, but we torture our amyloid patients because they're willing to be tortured with 5 questionnaires that we ask them on every visit, every 6 months, trying to better understand the natural history of the disease.
yeah, same, every 6 months.
Yeah, we do similar. So I'll ask you, this Melissa, Vutrisiran, is the therapy needed lifelong when started? Wouldn't be better as a this is kind of asking, wouldn't it be better to knock down TTR instead of just stabilizing? Well, we don't know. But
Yeah,
I'll ask you about the jury.
So I'll take the first question. So yes, this would be, at least from the data that we know right now, this would be lifelong, every 3 months. Of course, kind of looking at gene editing as a one-time infusion, but for the vutrisiran, it would be, at least from the data that we know, lifelong. And the second question, we just don't know yet.
Yeah, I mean, I think there are people who definitely believe that one therapy is going to be superior to another. Again, I think we should be driven by data at this particular point in time. The other thing that's confounding is, at least in Helios B, there were 200 patients who were on tafamidis at baseline. They weren't randomly allocated to, obviously, the tafamidis, but they were randomly allocated to get vutrisiran or not. And while there was no p-value near significant whatsoever, there was numerically less events. I must say, in HFrEF, we don't wait, as we heard this morning, to add on, all 4 pillars of therapy. We try to give them all. One wonders in this disease if you need to use, if combination is effective, do you need to use it up front? Unfortunately, the biggest issue, really, for using these drugs is, I keep harping on it, but is the cost. I mean, it's just really mind-blowingly astronomical how much they cost. And I can't really fault insurers for tiering therapy and asking, for good data before they endorse, people being on combinations. I was just going to ask last 2 questions, one to Sarah, one to Melissa. Sarah, could you comment a little bit further about this trial? You mentioned REVEAL and the PET scanning agent.
Yeah, so we've been involved, our centers, with an agent created by Jonathan Wall at the University of Tennessee. So he created like a polysaccharide, polypeptide that binds to any form of amyloid. And already we've both kind of published very preliminary data showing that this is highly sensitive to pick up amyloid in the heart. TTR, any form of TTR, as I mentioned earlier, we see some of the variants don't show up as positive on PYP, DPD, HMDP, and we don't know the mechanism for uptake of those bone avid radio tracers in cardiac amyloidosis. It was just like a nice coincidence that we came across. And for years, it came across it in the 70s and 80s, and then people were like, oh, it's not that useful because we didn't have the light chain assay to understand that it was more TTR than light chain, but that's going into that one, not the evusematide. So this novel tracer has been kind of synthetically made, this polypeptide. So we're doing a phase 3 study to see if it can just pick up all forms of amyloidosis. So not just TTR, but our AL, apolipoprotein A1, apolipoprotein A4. So, you know, it looks like it picks up disease a lot earlier when we've looked at our kind of small numbers than what we see with the bone avid radio tracers. So we could end up picking up cardiac disease much earlier and then hopefully initiating therapy much earlier. So I think one of the questions down the road will be, how soon do we initiate therapy? Do we do the evusematide scan that's positive and start people on therapy? Yeah.
And then, Melissa, you were very effective in your family there of getting family cascade testing. Can you just comment on your perspective on the importance and what your suggestions are? Because I think that's potentially a life-saving intervention for many people.
Yes, absolutely. So, you know, once someone has that mutation that gets identified, then the first thing that we're talking to them about in clinic is going to be having their first degree relatives tested. But all of our patients do get plugged into our genetics clinic, and so they also meet with a genetics counselor as well. But it's ongoing discussions, and I have had sometimes patients that say, well, my family member doesn't want to, and then I always just offer to, you know, that continual guidance, continual recommendation, and then if they get tested, that I'm always happy to see them in clinic and help facilitate. But I think having the genetics clinic and a genetics counselor has always been very helpful for us. And then really it's just ongoing discussion with our patients. I think that the amyloid patient population is one of the most informed patient population that I see. They always really know all of the data. And so normally they are very engaged to talk to their family members as well. But very important to try. And then, you know, there's different ways that have sponsored so that they can get the genetic testing for free, which has been very helpful for our patients.
Yeah, I just add that, you know, in carriers, there's now, I think you mentioned, but there are prevention trials. So if you're a carrier, there are 1.5 million individuals in the United States who carry the V122I variant because it's 3.5%. And if you multiply that by the number of individuals who are Black or West African ancestry. So it's not a small N who could develop amyloid. There was a paper by the Duke and Brigham group, with Scott Salm being the last author, in which they said that there's probably 1 million years of life lost in the U.S. from that one particular variant. So I think we have to do due diligence. But if you find someone who's within, say, 10 years of when their family member developed disease, they could enroll in a prevention trial. And the future could be that you might just take a stabilizer and prevent the development of disease in the future. So very exciting. Any last questions? I think we ran a little bit over, but I appreciate your time and attention and happy to take questions after.